Excuse me, I was just busy. So continuing with the management of the acute onset vertigo. So we were discussing about the various reason and various physical examination which you have to do to rule out. So vestibular neuronitis, it is also caused by the inflammation of the vestibular nerve, which you all know perhaps. The inflammation precedes the viral upper respiratory tract infection, herpes zoster infection caused by the immune-mediated sequelae followed by the viral illness. Now it is commonly seen in the middle-aged both sex, and vestibular neuronitis actually occurs in epidemics, outdoor respiratory infection, and the main characteristic of the vestibular neuronitis is acute onset of vertigo without hearing loss or tinnitus. So, and similarly PPV symptoms of vertigo are aggravated by chance position of the head. Loss of balance is more prominent of vestibular neuronitis compared with other cause of vertigo, because you can see the loss of balance is more prominent in the case of vestibular neuronitis, and bed rest and antiemetics can be used in the first 24 to 72 hours in the emergency department, and patient can be reassured the symptoms will improve with time, because there is no particular treatment in the case of vestibular neuronitis. Now, investigation, if are not routinely ordered for the patient receiving vertigo, however they recommended that glucose level of the patient vertigo should be checked, and CT we can do, MRI are indicated, like suppose if there is a examination not consistent with the peripheral lesion, or there is a prominent risk factor for CVA, etc., or neurological signs are present or symptoms of vertigo are accompanied by headache and all, so then we can do, and we can rule out from the emergency department to a specific department like neuromedicine or somewhere. Now, as far as I told you earlier, anti-vertigo treatment in the emergency department are only indicated. Now, treatment is tailored at specific cause of vertigo. Antiemetic medications such as beta-histine, as I told you, anti-vertigo, these are antiemetic also, and beta-histine, it also is a 5-HT4 antagonist, and it mediates through the emetic, through the emesis point also in the brain. So, it is also given as antiemetic, and it is used for symptomatic management of acute vertigo. Now, these medications should not be used for long term. Now, patients should be warned about the side effect of drowsiness, and benzodiazepine are not indicated, and the lifestyle medication should include, if there is some type of like secondary, if there is a cardiovascular causes of hypertension and something like that, then secondary lifestyle changes must be given by the emergency medicine and by the emergency physician. And like salt restriction, avoiding coffee, and assessment of management of patient risk profile important. Now, some of the cause may be unclear. Now, there may be some of the cause which are not been clear in the emergency department, and those patients should be sent to otorhinolaryngologist or ENT specialist. Okay. Now, this was a continuous of my previous video, which was paused due to some of my reason, because now, very simple question it is asked, that discuss the management of otitis malignant MOE, malignant otitis externa. Okay, they will, in emergency medicine, they will give you a simple one-liner question, and they will be tell you to discuss. Now, what is MOE? MOE is a serious and potentially life-threatening infection that affects the external ear canal and adjacent structure. Now, it is usually caused by the most commonly the bacteria which is the positive for the malignant otitis externa are Pseudomonas aeruginosa and Aspergillus fumigatus, also Proteus mirabilis, Proteus species, Calebsilla, Staphylococci. Okay, basically it occurs in the older and with underlying medical conditions such as diabetes or immunosuppression. Now, this should be borne in mind, because malignant otitis externa is actually the disease of the old. So, and the pathogenesis, the infection can spread the bony erosion and invasion of the distant tissue, causing the facial planes. It can also cause venous sinuses with the involvement of the skull base and surrounding tissue, leading to the cranial nerve and intercranial structure. And when the infection reaches the temporal bone through the fissure of Santorini. And what are the clinical features you observe? Now, what are the clinical features you observe there? These are unremitting pain, pulmonary ear discharge, systemic illness, hearing loss, granulation tissue of the ear canal, possible facial nerve palsy. Facial nerve palsy is very much common in the case of the malignant otitis externa. Now, how will you diagnose that? For the diagnosis, investigation like WBC count, sedimentation rate, CRP, blood glucose. Now, biopsy of the external auditory canal should be obtained to exclude other cause such as malignancy or cholesteatoma. There can be other cause also like malignancy, so you have to take the help of a histopathologist or pathologist. And CT scan, you have to ask the radiologist, and it will detect a bony erosion, demineralization, and destruction with body cortex of the mastoid. Here MRI will be superior. I think MRI will be more easy with detecting anatomical location of the soft tissue components, also better in evaluating the intracranial complication. Now gallium-67 tumor imaging is useful tool to monitor the resolution of the disease. The affected area usually shows increased uptake. Now Tectium-99 methylene diphosphate bone scanning is useful for initial evaluation of the disease, but the test is not useful for assessing the prognosis of the disease, and it stays positive for a long period. Now see, this emergency setting, we are not supposed to do this type of test. Rather, we should be only interested in the alleviating the symptoms. So though we have to look for the history, and before referring to the higher center or before referring to the otolaryngologist or neurologist, we have to just help them by giving them the proper history and probable provisional diagnosis. Now what is the management? Now management, if there is antibiotic therapy, the treatment depends on the administrative of systemic antimicrobial therapy. Here antimicrobial therapy with anti-pseudomonal activity, although most cases caused by pseudomonas aeruginosa have been identified cause of malignant toxicity, and therefore antibiotic mechanism should be according to the isolated organism. Now there may be hyperbaric oxygen therapy, although it is not widely used. So in the treatment of MOE, many studies shown no benefit, and surgical therapy is indicated, like reserved for the patient whom medical therapy fails. Okay, medical therapy has failed to cure the disease, and surgical therapy include local debridement, removal of the bony sequestrum, and the abscess drainage. Now these are the main thing which you can suggest after alleviating the symptom. The first is you have to understand that whether it is a malignant otitis media, what is the presentation. You have to alleviate the symptom by giving the analgesic and NSAIDs, and you have to control the hyperalgesia, all this, and then you have to talk to your counterpart, like whether it should be for surgery, whether it should be related by medicine people, for the ENT, joint team must be required. Now I'm coming to some of the GI emergency. Now this is a very important question again, which I want to discuss. Actually, describe the various scoring system in acute pancreatitis. Okay, scoring system is actually very important, and if the diagnosis is of the acute pancreatitis established, one should quickly work on the two lines. First, to assess the severity, that you can triage on the patient and decide whether to send him to ICU or in the ward. Okay. Now secondly, one should try to establish as quickly as possible, because some of the etiologies such as CVD, stone, and hypertriglyceridemia it could need investigation, and it needs intervention also. Now the most important aspect of managing acute pancreatitis is assessment of severity. It is always challenging to talk to relative about severity of the attack. Now there are various scales to assess the severity, like Ranson scales are there, Imries, Apache 2, etc. But the easiest bedside is biased scoring. Biased scoring is actually the radiologic severity assessment score, or CT severity score, entire exercise assessment to know the patient have organ failure, because the outcome depends on the number of organ involvement. Now biased score is bedside index severity of acute pancreatitis. Now bedside score of the severity in acute pancreatitis is like blood urea nitrogen, BUN more than like 25 mg, 1 point. Impaired, if it is impaired mental status, then abnormal mental score with 1 point. SIRS, if there is evidence of SIRS, then you have to give 1 point. And age, again more than 60, 1 point. Pleural effusion, 1 point. So score, you can already got lower mortality less than 2%, 3 to 5, higher mortality more than 15%. So now Apache 2, the acute physiology of chronic health examination, was originally developed for critically ill patient with intensive care, and defining the features of systemic inflammatory response are mentioned, like temperature more than 38 degrees Celsius, heart rate more than 90, respiratory rate more than 20. So these are some of the characteristics of the SIRS. Okay, and the main treatment of pancreatitis, acute pancreatitis, is managing the pain and giving symptomatic treatment and thereby referring the patient to, if required, to surgery, if required to the gastroenterology. Emergency medicine only requires the severity to identify the local severity, to identify that it is, yes, it is acute pancreatitis or it is acute on chronic pancreatitis setting in, like that. So these are some of the GI and some of the head and neck emergency which I have just told in very less than. I will discuss again with some of the toxic emergencies, some of the like methanol poisoning and the other poisoning, and then I will come with some of the psychiatric emergencies also. Now, let me discuss about the very important. This actually has been come, so I am discussing in this part only because it is very important. Now, discuss the pharmacological restraint in an agitated patient in the emergency department. Now, this is very important. It came to the examination of the ED various times. Now, physical or chemical restraint of the patient are required whenever there is a possibility of self-harm of the agitated patient. Behavior dangerous to the hospital staff. Now, close observation of the patient is required always. Okay. To record the changes in the tone, speech, irritability, clenched jaw for the first line intervention of the right time, and physician must record the GCS before applying right measure for agitation control. And here we have to control the agitation in the patient. We have to identify, we have to take the history. And medication used for chemical restraint are haloperidol. The first we can give haloperidol, antipsychotic, which is a typical antipsychotic. Lorazepam also we can give. Now, few characteristic features commonly used haloperidol and lorazepam. Drug therapy allow haloperidol is commonly used as first line drug, 2 to 5 mg intramuscular, followed by olanzapine also we can give. It is atypical antipsychotic, 2.5 to 5. Then quetiapine also we can give, but we have to talk to our counterpart in the psychiatry and we have to refer the patient to the psychiatry department for the further needful. Quetiapine is also used. Benzodiazepine like lorazepam is also used for if the patient is not being controlled by this also, we can also give more higher antipsychotics like thyroidazine. But this is not indicated in the emergency department and we have to send the patient to psychiatric department for further needful evaluation. But before that we have to alleviate the symptom. This is the mainstay of the treatment of acute agitated patient. And there the diagnosis of whether it is a general anxiety disorder or whether it is a agitated disorder, mood disorder, whatever it may be, they may be diagnosed. But in emergency setting, we should always try to alleviate the symptoms and try to gather as far as practicable the main symptoms, what is happening and what is the provisional diagnosis, that's it. So today my question is up to this only, and the next in the next coming video, I will come with the toxic poisoning and some of the cardiovascular emergencies, some of the CNS emergencies, and I will discuss their questions more related to which come in the DNB or in the MD examination, in the PGT, etc., which comes more frequently, and I will discuss and I will try to solve those questions. And it will be rather 10-15 years before and maybe recent to 10-15 years before, to be more precise. Thanks a lot.